Good afternoon, everybody, and welcome to Medicine Grand Rounds. It is my pleasure today to introduce our Medicine Grand Rounds speaker, Dr. Audra Meadows. Dr. Meadows is a board-certified OBGYN. She's a professor and vice chair at the UC San Diego School of Medicine and an adjunct professor in the Herbert Wertheim School of Public Health. A maternal health systems innovator and equity champion, Dr. Meadows leads NIH-funded research, directs health system science and health equity education, and co-directs the UCSD Center for Learning Health Systems and the eStar Scholars Program. Nationally recognized for leadership, she advances health system innovation, maternal care quality and equity, while cultivating the next generation of leaders in health systems. And I'm giving you a very shortened version of her bio. She really is impressive, and she told me not to embarrass her by going through everything, so I won't. But if you want to read it, it's really impressive. So welcome, Dr. Meadows. We look forward to your presentation on a blueprint for health systems to achieve maternal equity, insights for broader health system practice. Pleasure to have you.
Thank you. Thank you for having me. I'm really excited to discuss something that is very near and dear to my heart and that I'm very passionate about, which is addressing maternal health, but then also addressing health systems in a way that our country actually provides care to those our populations and how effective we are with that. And so in the work that I've done, I've learned over the years that what we've learned in maternal health is really applicable across the board in terms of health systems knowledge. So hence the tagline of insights for broader health system practice. So I'd like to just first say that I have no disclosures. We all, I guess, strive to have disclosures when in life, but I don't have it. I do have some learning objectives for you, but I also have some personal goals for myself too, and given this talk. And so some of the learning objectives, I'll just look at them with you. And that is, I want to explain why advancing birth equity is a national imperative and a signal for health systems change and challenges. That's important because we often talk about a lot of health inequities. We're in a time right now in our country where socio-political fabric makes talking about equity, diversity, and inclusion very uncomfortable and puts barriers to that. And we still need to continue to do the work that we do because as clinicians, researchers, et cetera, scientists, our goal is to advance health for our populations. Our goal is to advance medicine and health discovery and innovation. And in doing so, our goal is also to make sure that all populations benefit and not just some. And when we see those barriers there, because the data tells us that, there are ways for us to begin to address that. So I'm going to tell you a story about how I got on this journey and where we have found ourselves in some of the work that I've done. I also want to make sure I underscore some of the perinatal QI strategies that we have employed and show where some of the ways that we've taken an approach and a framework for this can really lead and advance medicine in other areas. And it can inform these systems-wide efforts that you may have also with these other areas of reproductive, cardiovascular, and metabolic disease and health related to that. I want to look at some of the key quality improvement strategies that we found in a couple of papers. So I included some papers that we were writing across the journey of this work so that you can sort of follow almost like breadcrumbs to where we landed. One thing that's really important that if you walk away from this talk and you're able to say, data collection and disaggregation is really important to this, then that'll make me really happy because I think that's where, not only do I think, the evidence shows that's where we've been able to make the story really come to life, really be able to show that the work that we've done has moved forward and led to improvements, and I'll show you that along the way. I also want to showcase some health systems. If we're talking about how we can find health systems challenges in the work that, and in the outcomes that we're dealing with. What we can also show are some health systems that have, I don't want to say determined, but some health systems that have seen that, done something about it, and really been able to show advancements. And so we'll talk about that too. So let's start here with lost mothers. I don't know how many of you may be aware of this, but I'm going to take you all the way back in almost 10 years to 2016. I'm sorry, 8 years to 2017 when this was published. And so this was published by ProPublica. And it was also widely broadcast across NPR and other spaces, and it was the Lost Mother series. And so if you hadn't heard about it, it really gave a lot of folks pause, because this wasn't just an obstetrics conversation or just in our areas. This became a conversation even greater for the entire country. And just looking at the title, an estimated 700 to 900 women in the U.S. died from pregnancy-related causes in 2016. We identified 134 of them thus far. I mean, that really gave people a moment to say, wow, these statistics that we used to know about at that moment, because many of us in that space understood the statistics, but understood also that there wasn't the level of national attention that this came. This came from social media bringing this national attention. One particular person that was among the deaths that happened in 2016 was Kira Johnson. And so we were able to start to see those statistics become human faces, and it humanized the problem for us in this maternal crisis that we were in, maternal health crisis. And we were able to understand that there were families forever changed by what was going on. We wanted to start thinking differently about it. Overall, what we've been able to see with this work is that maternal deaths, and they are rarely due to rare physiology or even common physiology. The deaths are happening, they are due to the fact that there are systems challenges and systems issues that are getting in our way. One of them is delays in recognition, delays in diagnosis, delays in implementing what we know to be life-saving treatments to help move care forward for somebody. And instead we're getting poor communication, our cognitive biases move forward for us. And these widespread, now preventable systems challenges are things that we see in obstetrics, but they move beyond obstetrics into other parts of the health system. Interestingly, when I was at a conference in 2017, and I had heard about Kira Johnson, her husband, Charles Johnson, was on the podium and was presenting what happened. And he didn't show any pictures at first. He gave a really great talk because it allowed us to all move into a place many of us were going back then. I was hearing the story, heard about what happened in my mind. I'm picturing somebody who was unhealthy. I'm picturing somebody who was obese. I was picturing somebody who had all these other issues, and I was taking the problem and making it about the person, and I was not making it about the system. And then when he shows the picture, which I'll actually go back to her picture, and you see that she was a race car driver, and she was active, and she was lively and vibrant, you realize this was not an issue related to her health or the way she tried to approach health. This is an issue related to the health system that she was engaged in. So from there, a lot of the work, a group of colleagues, I should say, I say friends because we've worked together so long now, it's a group of friends and colleagues, we really started to lean into understanding not that this was a challenge, we really wanted to frame it differently. This was also our opportunity to think differently about how our healthcare systems were supporting our patients. And so we wanted to lean into this call to action, and I want to first start with giving you some of the national data to look at how this has been a challenge over the years, and then really take some of these myths and squash those, because that becomes important, because we do have a lot of thoughts about why this data is what it is. And then we'll move forward into what we decided to do about it. I don't want to spend any time on any of the data slides I'm going to show, really trying to understand what the slide show, because there's a lot of different visualizations of data. Just know that here, the very top line is the United States, and that's not where you want to be. You want the top line to be down at the bottom. All these colored dots along the side and the colored lines that you see are different countries, different high-income countries that are comparable to us. And what we've seen over the years, and this is older data, 2018 to 2020, is that we were seeing in that time frame, right after we heard that ProPublica series and many people started talking about it, our rates were still going up. In other countries, we saw that their rates were either plateaued or still going down. So then what was happening there? Now you take this data and explode it out even farther and this is around that space, 2018 to 2020. What we were seeing is that steadily from the entire decade of the 2000s forward, those numbers have been going up. And now we're talking about maternal deaths here. We're going to shift to mortality, maternal morbidity in a moment. But just speaking about deaths, we then saw, as you can imagine, the spike in 2020 to 2021. That was related to our COVID pandemic, right? So the morbidity and mortality related there. And then we saw the numbers come back after we were able to get back into, our system functioning sort of as usual. Still though, I don't want to say that those numbers that we see at where we've been around 600 to 700 deaths a year, that's actually an acceptable number, right? There's no acceptable number for a death, but at the same time, those numbers are much higher than where we could be as a country. So this is still data looking at the countries, and this is now in a bar graph versus a line graph. And what we're seeing is that the Netherlands and Australia and Japan down at the end have these lower numbers. Germany, I always highlight Germany, at 3.6. And part of the reason is because during the COVID-19 pandemic, we also saw there was murder for Floyd. There was a lot of conversation that continued on that started to think about racial inequities. Now, when we do this work, we think about all inequities that's related to payer source, geography, race, age, comorbidities, et cetera. But when we're looking at this, we also see that the US rate at this particular time was around 24. For US Black, it was high. And so there's a lot of attention to Black maternal death and Black maternal health crisis. Actually, if you look by race, you can see over these series of years, 2018, 19, 20, 21, again, don't study it hard, just look at the green bar. With the green bar, we see that the non-Hispanic Black rate has been the highest among these other racial groups. We also though know that, sorry, that when we look across these countries again, another version of the bar graphs have turned it from one angle to another. I want you to see something though. When we take Black out, because we've even had folks in the media and social media saying, well, you know, it's because our countries are more diverse. And that diversity, and there are certain racial groups that have high numbers, that puts our numbers higher, right? And so when you look at this and you take Black out, which was the highest racial group, you see that for US white, it was 17.9. Still, remember that 3.6 for Germany. What does that mean? A country that would identify as not as racially diverse and having a higher percentage of white, people who identify as the race group of white in Germany, what is different about standing on German soil versus standing on American soil, right? That became important because then we were able to start to take the concept of biology out of this racial argument and begin to think about it matters because where you're standing and where you're getting the care that's delivered. So it matters for the systems of care. We also wanted to talk about this, which is age. That number that I showed you with race, the highest number you saw was 55. It has gotten up as high as 80. But if you look here, the highest rate is that by age. 106 between 2020 and 2021, and then down here it came back down to 55. Still though, that is the highest risk factor, those who are 40 and above. So if you look, the dark blue bar are those who are 40 and older, and those who are 35 and 39, which is another group that's where we start to use that phrase, advanced maternal health. I'm sorry, advanced maternal age. And so when you see patients coming in and they're pregnant and say, oh, they're over 35, they're at higher risk. That group that then goes from 40 and above, they are triple the rate of what they are at the age group between 35 and 39. But you can see there's an appreciable increase though with age. And so some of the dangers related to what can happen with comorbidities and with obstetrical complications continues to increase with age. So it's something for us to pay attention to. And it's something for us to pay attention to in terms of where people are seeking care, the level of hospital where they receive care, and then whether or not those hospitals have the implemented protocols and the team-based protocols in place so that they're bringing the highest level of evidence-based care there is. We also know that there's differences by geography. So this is a picture of the country, of course, and you can see the dark blue. That's what I want you to look at. The dark blue is where some of those outcomes are the worst. The Southeast corridor, we know that those numbers have been bad there. What strikes you though about this graphic? Anything in particular? Where it's darkest blue? It actually tracks with other elevated rates, right? So if you think about overall death, not just death related to being pregnant, overall death rates are highest in the states where the darkest blue, where it's the darkest blue. Infant mortality rates are highest in the states where it's darkest blue. Obesity rates, cardiovascular condition rates are highest in these states where it's darkest blue. So they all tend to track. So these states tend to track with a higher overall morbidity and mortality as well. And so it tells us something about not who lives in those states, but the systems of care available and the access to care available in those particular states. And I wanted to say though, no state though is without racial inequity in particular. So this graphic is from the Commonwealth Fund. Many of the graphics are from the Commonwealth Fund. The team there does a lot of work to look at the data across the country and start to understand where some of our challenges are. And again, don't study it. What you need to know though is the dots represent different racial groups. Every single state across the bottom, the 50 states and territories, you see a line between dots. Any state that's doing it well, you just see a collection of dots or one single dot showing that there's no gaps. But you can see that this is saying that there's gaps everywhere. So this slide just tells us that there are some states where we do better. So you can see our state is one of them, California. I actually did work in a state that's also another one that was done really well, and that's Massachusetts. Some of the things that we can say about the state is the way we have leaned into maternal health care from a perinatal quality standpoint has been really robust. In some of the other states, not as much, but gaining traction, and they have greater barriers to what it means to put that kind of care forward as well. So no state does it well. It's across the country, it's regionalized in certain parts of the country. And then on top of it, another thing that we've learned about the data. So years ago, there were some policies that were passed. Very happy about those policies that allowed for funding for there to be maternal mortality review committees in states. They were able to look at the death rates through death certificates and look at the different cases of death and learned what some of these reasons were. And when they looked at what was happening, they were able to determine preventability. And we learned that 84% or just over 80% of deaths were preventable. So again, we started with Kara Johnson's death was not due to a rare physiology. It was due to systems challenge. We also are seeing in other states, these deaths are not most often due to rare physiology or challenges of diseases that we can't treat. It's due to systems challenges. So when we know that, the next thing we want to do is really pull the lever on addressing the systems. I wanted to include this for many of you because a lot of folks like to ask, what are the different reasons and the causes of pregnancy-related death? And so here they are: hypertension, severe bleeding, cardiovascular diseases, mental health, COVID-19 is on that list as well. This is also divided by race. You can also divide this by geography to a degree as well. This just I want you to understand that the pregnancy-related death causes can vary. They can vary by age, they can vary by race, they can vary by region, they can vary by region because you think about specializations that may or may not be available to pregnant patients. And so there are various ranges that can happen, but the important part to know is that they're preventable. So just to wrap up this data piece, there was a call to action. We know that maternal morbidity, so mortality, but also morbidity has been on the rise, and that it's continuing to rise, and that we're higher than other comparable high-income countries. We also know that the rates can vary based on race, geography, age, other demographics. So we knew there were inequities there, and those inequities were pretty persistent. And I don't know how many of you remember entropy for chemistry? Yeah, great. So I was a chemist. That was my first job. Actually, I worked at Exxon before I went to medical school, and I was a quality chemist. I did lipid chemistry and petrochem industry. And what I recall about entropy is that things tend toward disorder. And actually, in order to keep something in order, you have to have systems in place to keep that order there. So when I saw the inequities and learned about this in School of Public Health, when I did public health school after I finished residency, because I was noticing so many things that I thought, did not tell us we're missing something here. And when I learned about inequities and started to understand them better, and I thought about how people kept pointing to social determinants, and again, pointing to systems outside of ourselves. My body is the healthcare system. Healthcare system's doing a little bit of this, right? Public health systems, society and social systems, et cetera. And I thought, well, how can the healthcare system be a part of this and do something a bit different? And so we also knew that the deaths were preventable. So it wasn't about the medicine. So the medicine clearly was there and was good, but we did know that there were some systems issues, and systems can drive outcomes. And with that, what can our systems do differently to really drive outcomes toward the positive and improve and closing gaps? So first I had to stop and imagine. I think we all have to do this sometimes before we go into our research and do our work. You have to really imagine the ideal and like step in it, live in it, see what the grocery store within it looks like, what it needs to put coffee inside of it. Like, what does it look like to have a healthcare system that provides quality care? And I didn't use the word high quality. Quality just with the definition of the 6 components. I'll show those in a moment. When it provides quality care and it reports optimal outcomes, meaning not just the outcome in terms of the statistic around rates of heart disease, et cetera, but actually experiences as well. So those stories, the qualitative data and the quantitative data. And think about it for not just what we consider often the population, which is what my residency experience was. So we talk about breastfeeding. Our population, 80% breastfeeding. And the word "our" really got to me. And how do you break down these words and start to really get it a little bit more nuance and unpacking? Which populations, which groups, based on certain demographics and based on intersections of demographics, who is it that we're missing that we need to support? And so when I learned to think in that way, when I was in residency and then finished my public health degree, it was really nice to be able to put that forward toward the work we were looking at for this period of quality. So in Massachusetts, we had the beginnings of the period of quality collaborative around 2016. And we used to talk about it in this way, like as we thought about transforming systems, you think to the right, this house here is really what we've inherited. And some people look at something like this and they're not a buyer. Others might look at something like this and they see the possibilities of the next house. And when they see the possibilities, it's because they were able to unpack the fact that they can see that actually some of the windows look like they might be in okay condition. I might keep some of the glass. I may need to replace the panes. Definitely, it looks like there's a challenge with the foundation, but possibly the foundation doesn't extend across the entire house. Like they're really able to unpack it. And when you can do that and start to think that where is your transformational zone, you're not, as a plumber, going to do the windows and the foundation. You're going to mostly do the plumbing. But if you think about the collaboration and collection of people that can come in and repair this house, you can start to think about how systems improvement means to bring in a lot of stakeholders. It takes a lot of imagination to think about the time that it's going to take to make this repair, and then what it can do. And then once we've inherited this, it's actually incumbent upon us then to continue to keep up with what needs to stay improved. And so when we think about creating equality, it is continuous quality improvement. And that is something that's already part of the fabric of healthcare systems. And so it felt like, okay, this is something that we can do. And so I'll tell you the story about how we've gotten on that journey and what we were able to accomplish. But before I tell you that, I'm going to pause and say, why is obstetrical outcomes? Why are they important to an internist, right? And so many of you already have answers to this, but I'll share that in my thinking, it's because patterns of preventable deaths mirror the disparities that you see in chronic disease management. So it's not very different. We know that some of the systems challenges that we've run into that have allowed us to have these obstetric outcomes mirror some of the challenges that you run into, particularly in other areas. As well, pregnancy complications are also those early predictors of cardiovascular and metabolic disease. And so it kind of gives us a sense of who people are and what types of supports need to be put in place moving forward. So something fun that we were able to do in Boston when I was attending is we had a co-location. Physically, our space was like this conference room. Like the obstetrics general care clinic was here. And then where the middle of that table is, imagine on the other side, that was the high-risk OB them care. And so because we were only divided by a doorway, you could tell the difference.
So sorry.
Okay.
Myra talked to them.
So, like I said, I work in
I'm so sorry.
These sounds are actually sort of like meditation for me. I'm fine.
I apologize.
I just shoot jumped. Yeah. So we were able to co-locate an internist in our maternal fetal medicine clinic so that when we had patients who had diabetes and chronic hypertension or severe preeclampsia or significant maternal complications, we were able to also bring them back into an internist because we noticed that structurally there was a gap between primary care and what we were doing in obstetrics. So we were working on that as well. So let me frame this conversation a little bit with health equity. We know that most maternal deaths are preventable and that systems can change this. And that when we think about quality, what we know that was defined since 2002 by the Institute of Medicine, now the National Academies, is that quality care is safe. That's the first thing. We want to walk into a hospital and come out better than we came in, right? Safety is really important. Efficient, effective, timely, patient-centered, and equitable. So oftentimes it was actually interesting to me that we could see rates of inequities by data, or rates that showed inequities from the data. And folks would talk about it, name it, but people mostly didn't pay attention to it, almost as if they were inevitable, like this concept of entropy, that it was actually a backwards thinking that they were just supposed to be there, rather than thinking about what systems are keeping those differences and gaps in place. So I thought, well, if this defines quality, and I learned this in public health school, then there's no, to me, such thing as high quality or low quality. There either is quality or there's not quality. So I love to show this picture because it was a lot of us. There was a large group of us in Massachusetts at that time that were part of our state perinatal quality collaborative. And we put together a few different bundles. We used something called AIM, the Alliance for Innovation in Maternal Health. They already had prepackaged and vetted safety bundles, patient safety bundles related to opioid use disorder, obstetric hemorrhage, severe hypertension. We did all those and we put one in place related to equity as well, so we could start to get at this. So many of us had our own cognitive biases around what was happening. You know, we had all sorts of ranges of actually the biases, and not just the implicit bias that we hear people talking about where inequities are concerned, but just a range of these heuristics, these mental shortcuts that we tend to take to sort of explain things. And we realized that there were actual structures we could put in place and team protocols we could put in place and trainings we could put in place to try and turn some of this around. So here's just a graphic that shows a picture of AIM's logo because they have a large number of patient safety bundles and they're very helpful. So if you've ever worked in area quality or quality improvement in general and wanted to think about an example of really great safety bundles, I really want to point you here because they have some good ones. We started putting the work in place. The clinical work was easy. Technical challenge, right? Technical challenges are those where you just like, you know, light bulb is broken or the light is out, unscrew the light bulb, replace it. It's something that we all know how to do with a lot of logic and we just put things in place. We were having a greater challenge with our equity bundle, and that was mostly because people had sort of an adaptive challenge in their mindset where equity is concerned. They had a lot of other thoughts, and we didn't have a collective idea around why the inequities existed. So we did a lot of work to explain issues around biology not being the cause of this. That was one of where we needed to start because for so many people, the conversations around genetics and evolutionary biology help people to understand how race became the social construct and that the social issues related to where people lived, worked, and played explained these differences and not biology. We also were able to explain that, you know, things that would protect you that you may have learned if any of you have public health degrees, that were protected, like if you got greater education or if you just have enough money, you should be protected from everything. We learned that wasn't the case because even, for instance, Black Native women who lived in certain areas of the country that may have been geographically far, like rural spaces, or even if you were well educated and high income, you had higher rates of these negative outcomes. We knew that health systems failure was a big part of it, and we knew that bias, geography, and payer source really led to these challenges. I won't dive into this for too long, but I just wanted to show you that, particularly related to the obstetric hemorrhage bundle, what we did, we went back and put the hemorrhage bundle in place, and we just layered on some of the facts that people can understand. It's quite surprising. There were even other OBGYNs who came back to me and would say, I didn't know this, that they thought that Black women actually had higher rates of hemorrhage because they just bled more because there was something different. And we know that they don't necessarily bleed more. They're just more likely to die if they do have a hemorrhage. That's more a function of where they're getting care and not so much a function of their physiology of their body. We also learned that when it comes particularly to obstetric hemorrhage as a cause of death, almost 90% of the time it's preventable. If you can recognize and intervene in a timely fashion, that's where it's important. And I really like this part, the denial and delay piece, because that goes back to what I used to do when I worked at Exxon. So one thing that we did when we made these petrochemicals is we sold time. I worked at a part of Exxon where we would actually take these reactors, chemistry sets that you see when you drive along freeways and highways, and we would create protocols so we could bypass certain systems and we would make the same things but faster. And if you can make it faster, you can go out and take care of some problem that this chemical's, taken care of for your company. A little simply, more soon and more simply. And so this idea of denial and delay was really in line with that. And when I say the word denial, if you deny the diagnosis, if you just don't see it and it's not there, then to you it's not happening, we're not doing something about it, that delays care. That delay is what leads to morbidity, ICU admissions, and possibly death, and utilization of resources at high levels, lack of value care, because we're spending a lot of money as well. We also looked at it this way through a sociological fashion at the top, like internalized, interpersonal, institutional, systemic ways to think about how if a person enters care, prenatal care, inpatient admission, postpartum care, and outpatient, where are the different places and spaces and ways that you can help elevate the experience of meeting the needs of that person where they are with obstetric hemorrhage. And so, for instance, we said anemia protocols and hemorrhage counseling with therapy, for instance, are ways for us to have care in the outpatient space that really gets the institutional level. But interpersonally, having somebody that does a validated tool or universal screening helps us to really capture who these people are. So there are ways for us to put equity in place, but it doesn't have to feel nebulous and difficult and heavy and emotional and socio-political. It is the care that we give. We just outlined it a little bit differently so people could sort of see where they were giving equitable care and how they could move forward. Okay, so that was like framing it for everybody in the States. We did a lot of training, we got everybody on the same page, we started to have the same conversations. We started to have people really take a moment to notice where they were and have self-awareness around their own biases. I had to have the same moment for myself because I wasn't clear or aware of where these heuristics were coming in from for me, but I found them. Then we just start talking about shifting from talking about maternal deaths and maternal morbidity. And so we wanted to implement these safety bundles, and I want to take a moment to explain this here for any of the residents that may be here that may not be aware. What is severe maternal morbidity? So most often when it comes to giving birth, it's uncomplicated deliveries, right? That is 70% of the time. Then you have something like called maternal morbidity, which is just preeclampsia. Run-of-the-mill average everyday preeclampsia that we see often, if you treat well, people get over it pretty readily. Then there's the severe maternal morbidity. Those are the ones that lead to those unintended consequences for mom, possibly for baby as well, and can lead to some life-threatening scenarios. And then we have those maternal near misses, near deaths, and then the death at the top of that pyramid, right? So we're seeing this increase in severity here. How we define it actually in obstetrics are these 21 conditions. 16 of them are medical conditions, and 4 of them are active procedures. So if you look through charts and you see someone that had DIC, acute renal failure, sepsis, on and on and on, those conditions and or in addition to having had a blood transfusion, a certain amount of blood, and hysterectomy, ventilation support, temporary tracheostomy, these people get captured in the charts. That's important to know because the way we learn about estimate rates in the public health space is through this data, right? And we know what administrative data does for us. People get it wrong a lot, right? And so when we look at this data, we have to then act on this data to try and get these numbers down, and people weren't reacting. And I couldn't quite rectify why we would see these gaps, and then folks would be like, high rate, and it kind of keep going on, and it became obvious through the study that what people were seeing was that what they experienced on their labor unit and what these rates were didn't tend to match. And so we started to try to understand that too. So we actually written a grant, again, friends and colleagues of mine, to NIH, and we started a maternity optimization in Massachusetts, or Be a Mom study. And we started to look at these things. I'm just going to show you a couple of things that we ended up publishing. And so our specific aims are around data. We want to understand the data better. We wanted to implement safety bundles and understand their impact and whether or not the effect would be positive. We also wanted to look at doulas, because there's a lot of talk around doulas and whether or not they were going to actually make a difference. And so that was a 5-year study. We got funded in early 2021. We're just wrapping up that 5-year study. And so more to come on what our outcomes will be. But some of the early things we found is that what we noticed was that preconception, like before they were ever pregnant, right, and perinatal, while they were pregnant, hospitalizations were an indicator. That's something that we hadn't talked about before, because when did these deaths and when did these moments of morbidity occur? It could happen in the perinatal space, so while they're pregnant. Most often we talk about it at the birth hospitalization when they're giving birth. And then the greater portion of like the maternal deaths that you may have heard about happen in those postpartum spaces. And so we're focusing in right here on this little sliver, but there's this entire spectrum to think about. And on the upper end of that spectrum, what are we finding? And we realized that if we just had some ways to signal that someone was getting admitted to the hospital, they were seeking care in emergency departments and getting admitted for various conditions, that would help us understand who's at greater risk for these maternal issues related to morbidity and mortality. We also used longitudinal data, and we looked to find how we would measure severe maternal morbidity, and we were realizing that we were missing a good 20% of maternal morbidities by looking only at the birth hospitalization if we expanded across the entire peripartum. So we knew that there were lots of places to implement action, but that hadn't been talked about as much. And so we're really happy about that. We also looked at some of the trends and inequities by race. And what we actually found was if you look again based on different racial groups and sometimes based on geography, that for an African American or a Black woman or a Black pregnant person, every condition, there was a raise in rate for those conditions for that person. And actually, obesity wasn't necessarily linked to it. But for someone who was identified in Massachusetts as white, obesity was linked to it. So it sort of mattered. So this data wasn't there again. You know, when I would present this often, people would say, so see, there's something biologically different. It's like, no, you just use the data to know where to target. So then it became pretty obvious that I needed to help put in a framework, and I'll tell you about that in just a second. Here are some of the data that we pulled, where we were able to look across 2021 to 22 through some of the bundles, and we saw that pink line at the top really is just those SMM rates from hospital data, from what we saw in what was reported back to the public health departments. But that blue line is what people saw from their own chart review, because internally hospital teams do their own chart reviews. And so they were seeing this gap. And we had to flag that gap in order to really bring attention to get people to want to pay attention to the data differently and do something about it. Okay, so in the study, for our specific aim number 2, we did implement these safety bundles. And in implementing the safety bundles, we wanted to look at when we had a universal goal, but a targeted approach. And so many of you have heard talks on target universalism. Is that a concept many people are aware of? So with target universalism, John Powell at the UC Berkeley Center for Othering and Belonging, he created this phrase, target universalism, around 2009, and it talks about an approach, basically as a framework to address systems. You can apply it anywhere. It doesn't have to be with an healthcare system, systems of education, economics, housing, etc. That if you were to look at creating a universal goal, no different than you do with any team, like the team of people who want to address this problem, we'd have a similar and shared goal. Once you have that goal, you need to look at your data. We all do that as well, right? You want to see where the benchmark is, what the average is, and you want to see, based on different populations, the populations that you know you serve. So you put those in and you see where those differences are. And when you see where the gaps are, you then look at each different population that has a gap and you target, and you understand what the barriers are for those groups, and you target the intervention to those groups, and you go from there. The way we approach that, I'll show. We talked about it through a paper we wrote called Strategies to Promote Maternal Equity and the Role of Perinatal Quality Collaboratives. That our first approach is that we said and saw, and so this is the lead, actually, I'm burying the lead a bit by this whole talk. Perinatal quality demonstrated that there was a power in shared goals. Across the country, we were developing these PQCs. Early on in Massachusetts, we had one, but across the country now, almost all 50 states have one. And they were very active, and the most active and well-known was the one here, the California Maternal Quality Care Collaborative, or CMQCC. There's also the CPQCC for the neonatal portion. What we saw was that we set a goal of safe, optimal birth outcomes for all. Now, it gets much more granular than that, but that's just the overall goal. We engaged APQCs, we implemented patient safety bundles targeted to populations that were furthest from the goal, right? So we tailored a lot of our interventions towards the group that was furthest from the goal, knowing that that would still help other groups, but while also running the data continuously to see where we're missing the mark. We also learned that systems responded favorably. Now, in this paper, when we published it, I want to show you this. These 3 papers that have been published, one on the California PQC that looked at 100 hospitals or 99, the Texas hospital system that delivered almost 10,000 deliveries in that hospital. So that's the Texas Medical Center. And then a health system that had 5 hospitals in Pennsylvania. They all did the same things. They employed these 6 strategies that we looked at. And when they employed these particular strategies for the perinatal equity, they actually showed closures in their gaps. So if you look here again, don't spend time looking at what these numbers show, but just the different colors represent different racial groups. Those numbers were on the rise pre-intervention. Here is where they were going to start looking post-intervention. All the numbers started to decrease. Not only did their rates of SMM by hemorrhage specifically decrease, the gaps were starting to close. And even though you see that difference there, that was not statistically significant any longer. And then over time, 9 months later, that gap remained closed and still remained. Any differences that you saw, the number wasn't the same, was still not statistically significant. In California, looking here, you're looking at blue versus orange. The blue bars are pre-intervention and the orange is post-intervention. They also saw a reduction overall, but you see that through their targeted approach, they saw a reduction in each racial group, and the gap that used to be there between the different blues, so white and black blue bar, the gap between 6 and 9, notice when it goes to 5 and 6.9, that gap that was starting to narrow now also became not statistically significant. And we saw the same thing at U10. They saw a closure in their gaps as well as a decrease. And these papers were out there in the world and no one was talking about them, but they really were showing and proving that perinatal quality works. And it's working when we have leadership and data and protocols in place. We have all this great information that's out there, as long as you're putting them in place and making sure that it can happen, because making sure that what we know is the right thing to do is the thing that we do is not always easy and it's not always done. And there's a science to that, implementation science, of looking at feasibility, acceptability, those kinds of things when we want to move in that direction. So these were the strategies that we talked about: communicating maternal equity as a priority for leadership. So leadership really leading, giving us data dashboards, helping us collaborate with our strategic partners, collaborating with the community, educating our clinicians as we talked about, and then collaborating on implementing these best practices. So we co-designed the interventions together. So the first thing that we learned is that perinatal quality works, and especially works when we have this shared goal. The second thing we learned is that leadership and governance helped us to align the goals. And so when we wanted to communicate this, we actually needed our leadership to be aware of what we're doing. We needed them to be able to put resources toward it, make it part of our mission. So in doing so, we actually engaged in Massachusetts across this year, September 22 to October 23. These are all the hospitals that were submitting data to us, and there were 48 hospitals in Massachusetts that give birth, that have birth facilities, and 22 were engaged in this project with us. And you can see only about half of them had leadership and a formal equity team to support the work, meaning they were actually given protected time to talk about these things. By the end, we were able to help get all 22 with leadership on board to have a formal equity committee to think about these things. Now, committee's only as good as you actually have a goal and work toward it, right? And so what we did find is that, again, if we were successful, this whole thing would be blue. The fact you see so much orange shows that we weren't very successful in helping them move to making sure that they had a shared goal even within their committees, but we did improve over time. And what we were trying to help them do is just set some goals that they could go toward and close gaps. Here, around the time that we started the study, I then transitioned here to the University of California, San Diego, and I started in our department. And we actually have an equity committee, but we call ours our Culture and Justice Forum. We look at how do we create a culture of equity and how do we think about social justice and even just our ethical responsibility in medicine toward justice for all patients. And so we look across our department to see everything from wall art to quality outcomes. So what are we seeing and what can we do about it? And our committee, a group of self-nominated ambassadors across our department who work to accomplish these goals. So we published on that. The third thing we learned in the study, though, is that culture sustains the work. And so a culture of equity is one where everybody's working together to achieve this outcome. This is within that framework of target universalism that John Powell espouses. And so in order to get there, we knew that if we trained clinicians, provided them with tools and strategies, we increased health equity grand rounds, we wanted to bring equity to the conversation so that people could see this wasn't a nebulous concept, that it was something to actually do. And what we were able to find is that people, when they started becoming educated, again, this is across that year, more people wanted to be educated. So we had to keep giving these training sessions over and over. And it was really great because we got some funding to actually bring in our trainers and have them do state rounds. So that way we could continue to increase both the education for our obstetric nurses and our MDs. And that was a really important part of it because then we could all speak the same language again. So first we talked about perinatal quality of works. We can close gaps if we do what these safety funnels are saying to do, if we know how to do them well. The second thing we learned, of course, is that leadership needed to be a part of it. And the third thing is we needed to have a culture of wanting to have the same, work toward the same goal. The fourth thing we learned, though, is that data showed us who was furthest from the goal and it helped us track progress. And so we're able to leverage that through not only stratifying data by race, ethnicity, but also SOGIs, social determinants of health and geography, something you can do well here at UCSD because it was pretty uncommon that I had seen that an EMR has that information in the storyboard so you could really run those statistics. So that was great. And those dashboards really helped us to move forward. But the important part was us to also include patient-reported experience measures in there so that we're getting that qualitative data in addition to the quantitative data. So what we were able to see here is how many people were doing that. This is blue, so that means we were pretty successful. We're doing what we wanted to do with people stratifying data based on race, ethnicity, and language, which is really important. Where we saw people having more of difficulty with is when they were stratifying from race, ethnicity, and language. They had the tools in place here, but they weren't always doing it for all their projects. And so if you're not doing it for your projects, how do you know what to target, right? Like if you're only saying 80% of our moms that give birth here breastfeed, what do we know about the 20%? If there's something that feels pretty celebratory about the number 80%, so when I hear people report that, they often like, yeah, 80% are breastfeeding. And you're thinking, there's so much to that. Like, what does that tell me? And what should we be doing about it? So what we learned overall, though, in this study, and there's a lot of data that we're still assessing right now, and a lot of data slides I didn't show because I wanted to really have a conversation around this, is that if you have champions, if you have people that really want to do the work, your leadership is on board. If you co-design interventions, once you've got this universal goal and you can see the data where there are different gaps, you can really start to move things forward. If you create a culture and have these tools through your data dashboard to help keep the progress moving forward, you can find yourself successful. And if you continue to stratify your data and review cases to understand what those differences are, you can find yourself being really successful. And this all comes back and tracks back into internal medicine because many of the systems challenges that we were able to find, this issue around something very simple. I'll give you an example with our hemorrhage bundle. If a person is giving birth on a labor unit, they're going to bleed. I have not seen it happen any other way before that, right? Whether it's a small amount or a large amount, it always happens. So if they bleed heavily, we need all the materials and medications and equipment necessary to manage this hemorrhage. So where do we keep this? We have a hemorrhage cart. One thing that we wanted to do that was a really simple intervention was all hospitals that serve all populations needed to make sure that they had updated hemorrhage carts. So we did training on what was in the hemorrhage cart, where you put them, who keeps them updated, and just making sure there's a process around that because part of the problem was in some of the low performing hospitals, patients who were dying related to hemorrhage or having significant morbidity was because they couldn't find the hemorrhage cart, they couldn't get the key to the hemorrhage cart, the medications in the cart were expired. These very simple things. That's unacceptable because these are things that we can absolutely do. And so when I'm saying that as an example to show there are lots of things that when it seems we get these big articles out there, oh, we've got these big gaps, these big disparities, we keep hearing it, we start to develop this bias in our minds where it is, we accept that they're always going to be there because we don't unpack them to see why these differences are occurring. And when you start to see where they are and you realize that you have the tools to fix them, it becomes really nice and cathartic to be able to put those tools in place and move forward. So improving maternal outcomes It's a systems level problem. It's not an individual problem. It's not a problem related to communities. We were able to do this work regardless of social determinants of health. We were able to close gaps despite whether the person came in hungry or fed, housed or unhoused, insured or uninsured. That's the important part. That's not true for all chronic conditions. That'd be very different for instance diabetes, right? Because you do need to be able to have housing and medication storage and have outpatient therapies that are up to date. But when it came to these issues around obstetric hemorrhage and some of the things that were happening on labor units, we were able to close gaps. And you can only imagine if we're able to close gaps here, there are other places we can find this in healthcare systems as well. We know we cultivated a culture of equity so that quality standards were met for every population. We were really raising the bar. And we knew that the strategies were working. That was evidenced by the fact we were able to close these gaps. And so again, this is a story of a person. I started with Kira Johnson. Now she lost her life due to an obstetric hemorrhage at a hospital, Cedars-Sinai, here in Southern California. There was a lot of press around it in the beginning, and then more press after the case was done. And that's always the case. The press that was done after the case was over was much smaller than the first month that hit the news. And you only realize that just being able to do something very simple that they did at Cedars-Sinai, post that case, they did a lot of work to improve quality. They put in something in place called a rapid response. Many of us have rapid response. At that time, they didn't have it. They were waiting for one particular doctor to come in and fix this issue that she was having with bleeding. But with a rapid response, the nurse now is empowered to just send a page, and every obstetrician that was available could come to her rescue. And imagine if they just had a simple system solution in place. This person's home right now with her 5 and 7-year-old. And that's not the case. So knowing that these are systems issues, and knowing that many of you are systems innovators, systems transformers, you have the patient populations that need those systems updates in order to make sure that their care is quality and that their lives are moving in a positive direction for population health. I can only imagine that some of these lessons would be things that you could apply as well. So I'll pause there for questions to say thank you for inviting me.
Thank you so much. Any questions in the room? Dr. Ghosh, of course.
Thank you. I especially enjoyed your.
Tupperware
I'm so used to bangs. I liked how you used the word entropy to bring in this, and from the edge of chaos comes patterns.
Yes.
Now, about the pattern, do you think, and what do you think might be the implications of, in 2014, the controversial thing happened where all these companies, first it was Facebook and then Apple, who jointly said, women in career, freeze your eggs, have your child when you get time. And then, of course, Google joined in 2017. And it was controversial. And then you showed me this alarming statistics of age. And so my question is, was age a factor in the other continents? Are we in this country just waiting too long if women are in career to have the children? And second, what the impact of more and more of that? I mean, here at least we get a year of delaying tenure every baby we have. I think that's still the policy, if I'm not mistaken. Okay. That's the rule, right? Depends. Okay. So anything you can.
Yeah, we don't have the comparable data because
Okay.
everyone has to slice the data the same way in the other countries. I can only imagine their thrust for wanting to slice their data in that way when their rate is only 2.7 is probably not as great as ours. And so I imagine that's why we don't see that data in the same way. It is definitely something that I'd like to bring up because it should affect counseling in particular. So, I completely believe in and practice shared decision making when it comes to deciding when someone plans to give birth. At the same time, they need to be aware of this information. And they need to be aware that by delaying, you do increase your risk. Now, what you do is you'll see friends and family members, right? Sisters, cousins, et cetera, who've been 35, 36, 37, 38, had a baby, they're just fine. It does matter how old you are with your first pregnancy versus if you're 40 with your third pregnancy in terms of your outcomes. And so what that data is still pretty packaged. It doesn't disaggregate whether these are prime members or multiparous women, what their comorbidities are, et cetera. But overall, as a category, those who are above 40 have higher rates.
Thank you.
Yeah.
Anything on that?
I have a question. Sure, yeah.
Tell me.
There is one online.
One
I think if you click on the more at the top, you can see the Q&A.
Oh, there, okay. I can show you here if you wish.
Oh,
About the
on the
construction.
more, yeah, there you go.
Ah.
There you
Okay, so let me read this. This is from Dr. Sine. Can you talk about how the closing of OB services might influence disparities in our health system? This is like 3 questions in one. Are there any innovative solutions such as partnerships or programs that we haven't tried yet that could be leveraged, especially for populations that have greater access barriers, which results in higher maternal morbidity and mortality?
Dr. Sandy, that's a great question, and it's something that we're looking at. So one of the things that I do is my vice chair role is vice chair of culture and justice. And one of the things that I set out to do in that vice chair role initially and continue to do now is create these partnerships with our community organizations that work to address maternal child health and maternal child health services through the public health department. And first, it was just about starting having conversations so we could think about who's doing what, because I didn't want to pretend to think that I was going to bring in ideas that they may not have already thought about. I needed to understand the history, the geography, the infrastructure, the who's there, how they're funded, and what their sustainability is, and where we could fit as partners. And so we've worked to do that for a while. There are a lot of gaps in California or Southern California, San Diego County in particular, and Imperial County. I mean, the word gap is even a small word for what's happening there with the rural experiences and the lack of services there. So we implemented things like a maternal health fair last May. We had one, and so we were able to bring in a lot of families to provide services and provide information. And we surveyed our families to find out what they learned and what they thought about it. And actually, overwhelmingly, of the 100 families that came and that were served, all of them said, "I met somebody here that's going to help me to move forward, something I need to do for me or my family in the future." That just shows how I think across the fabric of San Diego County, the ability for folks to get information may not be as robust as we understand it to be. I also participated in supporting a health fair a couple months before in last March. And we learned also there that services around just simple things like voting and things that make people feel empowered in their own communities really helps. And there's still a lack of information and education there in these centralized ways. And so we've been working to partner with teams to do that kind of work. There are really great frameworks that are already out there in other states of things that have happened. And so I don't think of it necessarily as health systems level interventions as much as state level interventions. For instance, some states have universal home visiting after giving birth. And so if you have universal home visiting, you can really be able to determine issues around social determinants of health as well as any health complications that they may not have picked up on, educate people again after they left the hospital. How many people can think if someone's left the hospital after having a baby and they retained every bit of information told to them in their discharge, right? No one. So those kinds of things only help bridge those gaps, and that's something that we don't have here. California is a large state. I was really fortunate to live in a little tiny state because you can see the benefit of how those things can really support and elevate care. So there's probably a laundry list of things that could be happening. Many of which are possible, many of which are, impossible without the funding and support. And then some things that we're trying to understand and learn from the communities now that we could be doing. But the closing of the OB services really has been a strong impact. It definitely has put a stress and strain on families to have to travel and go to different places to get their care in to give birth. I definitely hear the stories of people having to travel from cities that I'm now looking up on the map to see where they are and understand where they're located and what they're traversing to even get here to have their babies and how to coordinate their services if they're saying, this is my 5th baby and I deliver fast, but they live someplace far, how to make sure they're in the right place, especially if they've got medical conditions that may need attention. So there is a lot of work that needs to be done in terms of coordination of care. And those services don't exist here as deeply and as deeply as we'd like them to. But where they do exist, we do know that those gaps are not as great and that people have better outcomes and experiences. So thank you for the question. I hope I answered it.
Question?
Anything on the doulas?
Yes, so wonderfully, we do have a doula program here. It's called our Hearts and Hands Doula Program. We're one of the very few hospitals across the country that has an in-house doula program. Something we've done in partnership with this doula program that's been mostly led by our nursing side. So it's not necessarily in the OB department, but our strong collaborators, which are our perinatal nurses, is that we've been able to train culturally and linguistically appropriate doulas. So we've got a large refugee and asylum seeker population that's in here in Southern California. So we've trained doulas and had a few now doula graduations of those who speak various languages, Farsi, Dari, Haitian Creole, including Spanish and French and Russian, and now we're adding and thinking about Vietnamese and other languages. So we've got all of our materials translated into 10 plus languages for our childbirth education and welcome letters, et cetera. So we're working on how we're increasing the ability for us to communicate well with our patients that we're serving and making sure they know the kinds of services that we have for them to access, in addition to giving them the information they need when they're leaving the hospital, either their after visit summary or their discharge summaries. So doula program has been really a strong help. And they're very active. They've been involved in many of the births. We don't, of course, have as many doulas as we have deliveries, but of the people who are requesting and need those doula services, it's been a big help. And we're also partnering with those external doula companies that are not part of our in-hospital group. And we've worked, partner and train together just so that when they're here, it all feels like one big family and not difficult for anybody.
Other questions? If not, thank you very much for the very illuminating talk, and congratulations on all that you've done so far.
Oh, I really appreciate it. Thank you for having me.